Hello students, welcome to EPG Patsala. I am Dr. Prasanna Kumar Patra from Utkal University, Bhubaneswar. Today we will discuss the module Meaning and Scope of Medical Anthropology from the paper Human Growth, Development and Nutrition. The course provides an introduction to the field of medical anthropology. It includes the application of different forms of social and cultural analysis of the study of health, illness, and healing. The study of this module enables the students at postgraduate level to understand the theoretical orientation of medical anthropology. Medical anthropology is a subfield of anthropology that draws upon social, cultural, biological, and linguistic anthropology to better understand those factors which influence health and well-being. Broadly defined, the experience and distribution of illness, the prevention and treatment of sickness, healing processes, the social relations of therapy management, and the cultural importance and utilization of pluralistic medical systems. The discipline of medical anthropology draws upon many different theoretical approaches. It is as attractive to popular health culture as bioscientific epidemiology, and the social construction of knowledge and politics of science as scientific discovery and hypothesis testing. Medical anthropologists examine how the health of individuals, larger social formations, and the environment are affected by interrelationships between humans and other species, cultural norms and social institutions, micro and macro politics, and forces of globalization as each of these affects local worlds. Medical anthropology examines how health and well-being are socially and culturally constituted in comparative and transnational contexts and the ways in which culture influences the experience of illness, the practice of medicine, and the process of healing for the individual and community. It explores how the experiences and perceptions of the body, self or notion of the individual or person influence the illness experience. It is also concerned with how cultural values and practices dynamically shape and are themselves shaped by biomedical research and practice and the non-Western medicines and healing traditions. Medical anthropology is the study of human health and disease, healthcare systems, and biocultural adaptation. The discipline draws upon four fields of anthropology to analyze and compare the health of regional populations and of ethnic and cultural enclaves, both prehistoric and contemporary. Collaboration among paleopathologists, human biologists, ethnologists, and linguists has created a field that is autonomous from any single discipline, with strong potential for integration of physical and cultural anthropology. The field is also highly interdisciplinary, linking anthropology to sociology, economics, and geography, as well as to medicine, nursing, public health, and other health professions. Since the mid-1960s, medical anthropology has developed three major orientations. Medical ecology views populations as biological as well as cultural units and studies interactions among ecological systems, health, and human evolution. Ethnomedical analysis focuses on cultural systems of healing, and the cognitive parameters of illness. Applied medical anthropology deals with intervention, prevention, and policy issues, analyzes the socio-economic forces and power differentials that influence access to care. In this triad, cultural anthropology is most closely allied with ethnomedicine. In the formative years, some of the anthropologists favored identifying the field as ethnomedicine, while others preferred anthropology of health. The term medical anthropology prevailed, however, coming to represent a diversified range of orientations. History of medical anthropology. George M. Foster and Barbara Galton Anderson in 1978 traced the development of medical anthropology to four distinct sources: the interest of early physical anthropologists in human evolution and adaptation, ethnographic interest in primitive medicine, studies of psychiatric phenomena in the culture and personality school, and anthropological work in international health. W. H. R. Rivers, in 1924, a physician, is considered the first ethnologist of non-Western medical practices. Early theoretical work by F. E. Clements in 1932 and E. H. Achternetz also attempted to systematize primitive medical beliefs and practices. Paralleling theory development were early applications of anthropological principles to health problems. Since the 1940s, anthropologists have helped healthcare providers to understand cultural differences in health behaviors, as shown in Benjamin D. Pop's edited volume Health, Culture and Community, Case Studies of Public Relations to Health Programs, published in 1955. That was one of the first medical anthropology texts. William Caudle, 1953, was the first to identify the field, followed by review articles by Stephen Polgar, 1962, and by Norman Scotch of 1963. Academics, applied scientists, and clinicians enthusiastically worked in the 1960s to organize the emerging social science in medicine movements at national meetings of the American Anthropological Association, that's AAA, and the Society for Applied Anthropology, SAA. Caudle, Polgar, and Scotch were among the most active, as were Hazel Widman, Arthur Rubel, Dorothy Layton, Clifford Burnett, Marvin Opler, Marion Pearsall, Donald Kennedy, Benjamin Paul, and Charles Leslie. The Group of Medical Anthropology, GMA, was established in 1967 with Widman as chair, affiliated with the SFAA in 1969. As the Society for Medical Anthropology, the organization became a formal section of AAA, American Anthropological Association, in 1972. With Dorothy Layton, a psychiatrist anthropologist, serving as its first president, membership grew from 657 in 1972 to 1,523 in 1999, including a few hundred Canadian and other international members, primarily Europeans. Next to North America, Great Britain has the largest number of medical anthropologists. Most of them are concerned more with political economy and clinical issues than with biocultural perspectives. Increasing numbers of medical anthropologists work in Australia, Latin America, the Philippines, and India. Theoretical orientation of medical anthropology, medical ecological theory. Anthropologists, using an ecological perspective to understand disease patterns, view human populations as biological as well as cultural entities. Taking a systems approach in research, culture is seen as one resource for responding to environmental problems, but genetic and physiological processes carry equal weight. The evolution, demography, and epidemiology of humans are subject to ecological forces, as are other species. A key concept in medical ecology is adaptation. The changes, modifications, and variations that increase the chances of survival, reproductive success, and general well-being in an environment. While some applied research is a theoretical, others employ explicit theoretical frameworks. One notable framework is the political economy of health, also called as critical medical anthropology. Influenced by Marxist theory and dependency theory, this approach analyzes the impact of global economic systems, particularly capitalism, on local and national health. Political economists such as Shoer Morse, Hans Beer, Lynn Morgan, and Meryl Singer argued that change programs should not be attempted unless one also studies the social production of illness and poverty within the larger dynamics of class interaction, colonialism, and world economic systems. Critical clinical medical anthropology is an adjunct of political economy. This approach analyzes biomedical practice and the differentials in power and authoritative knowledge of practitioner and patient. Clinical anthropology has been influenced by Michael Foucault's writing on the historical production of medical knowledge, and the notion of the body can become an arena in which social control issues are played out. Usually focused on medical communication, the approach has been used particularly in relation to women's reproductive health and has also developed a controversial literature on the lexicalization of women's body through the work of Brigitte Jordan, Emily Martin, Rena Rapp, and others. Theoretical orientation of ethnomedicine. The ethnomedical perspective focuses on health beliefs and practices, cultural values, and social roles. Originally limited to study of primitive or folk medicine, ethnomedicine has come to mean the health maintenance system of any society. Health ethnographies encompass beliefs, knowledge, and values of specialists and lay people. The roles of healers, patients, or clients, and family members, the implements, techniques, and pharmacopoeias of specialists, legal and economic aspects of health practices, and symbolic and interpersonal components of experience of illness. Pluralistic societies often encompass several ethnomedical systems. Among these are cosmopolitan medicine, a dominant system in North America and in urban centers elsewhere, which emphasizes empirical research, naturalistic explanations, technology, and surgery, use of extraordinary intervention to preserve life, and hierarchical roles. Humoral medicine, derived from ancient Greek medicine, emphasizes that health reflects balance among bodily humors and their intrinsic qualities. This equilibrium derives from ingestion of inappropriate food and other substances, from change of climate, and from exposure to natural elements like air and water. Therapy involves restoring equilibrium through applying or ingesting remedies opposite to the state of the body. Humoral medicine coexists with other systems in Latin America, the Middle East, Malaysia, Indonesia, and the Philippines. Ayurvedic medicine in India and Chinese traditional medicine meld humoral elements with elements of other systems. A key concept in ethnomedicine is explanatory model, introduced by Arthur Kleinman 1980. Explanatory model or EMS are notions about the causes of illness, diagnostic criteria, and treatment options. In a clinical encounter, the EMS held by practitioners, patients, and family often differs. The ensuing communication and negotiation of decisions for managing illness led to cultural construction of illness, to the extent that disparity among EMS continues because of cultural, ethnic, or class differences. Communication remains problematic. The disease illness distinction is important conceptually in the study of ethnomedicine. Disease, defined clinically as a deviation from medical norms, is considered to be a Western biomedical category and not universal. Biomedical terms such as hypertension or diabetes may not correspond to diagnostic categories of a given ethno-medical system. Illness, in contrast, is the experience of impairment or distress as culturally defined and constructed. Cause of the illness may also be located in social and spiritual realms, so that ethnomedical etiology may include sorcery, soul loss, and spirit intrusion. In addition to negotiation of the meaning of illness, management of illness, and disability also occur in a social and cognitive matrix. Healing is often mediated by symbols and practices that induce conditioned neurophysiological and immune system responses. The placebo effect of the healer's behavior and symbols to induce healing or to reduce stress is of central interest in ethnomedical studies. Cultural psychiatry is closely allied with ethnomedicine. Many folk illnesses or culture-bound syndromes such as susto, actic hysteria, or amok appear to be psychogenic, although environmental stressors play a role in their onset. These folk illnesses do not fit easily into Western diagnostic categories. Ethnographic methods are primary in this orientation, and researchers usually do participant observation, sometimes becoming apprentices of healers and midwives. Some elicit ethnosemantic data on disease categories, causes, and decisions models in order to study underlying cognition. Interviews and life histories allow in-depth analysis of the lives of healers and patients, and medical discourse analysis is a specialized linguistic technique that studies the negotiation of meaning and power. Some specialists collect and analyze pharmacologic items. Others study the history of medical practices. Although traditionally researchers have worked in folk societies, increasing numbers are studying pluralistic societies such as Margaret Locke in 1980. Attention has been given since the mid-80s to integrating ethnomedicine and ethnoecology, as in studies of indigenous people's knowledge of medicinal plants. There is also strong interest in clinical applications of ethnomedical treatments. Anthropology. Theories of the cultural patterning of health behavior can be applied in any arena. Following the pioneering examples set by Margaret Clark, George Foster, and Brett Pelto, anthropologists work, for example, in clinics serving multicultural populations, in maternal and child health programs, on surveys of community responses to environmental hazards, on program planning and evaluation in psychiatric hospitals, on AIDS prevention projects, and on the reintegration of people with traumatic brain injuries to community life. The populations served are often people on the margins of mainstream society, like refugees, native peoples, rural elderly, drug addicts, people with disabilities, ethnic minorities. The difference between basic and applied research is that applied medical anthropologists deliberately become advocates for the community and attempt to do research that is useful and ethical. Applied anthropology methods are eclectic, ranging from qualitative to highly quantitative. Ethnographers have developed rapid assessment techniques to document community health needs during brief field trips. Others, trained in public health, epidemiology, nursing, or medicine, may do clinical or laboratory procedures or work with vital statistics. In quantitative approaches, rigorous attention is paid to sampling issues and sophisticated statistical analysis, and informed consent procedures are followed. As Carol E. Hill in 1991 points out, many medical anthropologists are now working outside academia and combining standard anthropological skills with technical planning and evaluation skills. Scope of medical anthropology. Currently, research in medical anthropology is one of the main growth areas in the field of anthropology as a whole, and important processes of internal specialization are taking place. For this reason, Any agenda is always debatable. In general, we may consider the following 6 basic fields. 1. The development of systems of medical knowledge and medical care. Second, the patient-physician relationship. Third, the integration of alternative medical systems in culturally diverse environments. Fourth, the interaction of social, environmental, and biological factors which influence health and illness both in the individual and the community as a whole. Fifth, the critical analysis of interaction between psychiatric services and migrant populations, that is, critical ethnopsychiatry. And the sixth, the impact of biomedicine and biomedical technologies in non-Western settings. Employment has been plentiful in medical anthropology, especially from 1967 through the 1980s. Departments of preventive medicine, social psychiatry, pediatrics, nursing, schools of public health, and public health service were employing social scientists, and training programs were also being established. Several national and international university or educational institution establishes the courses as well as training programs in medical anthropology, especially public health, to prepare for work in a wide array of academic, clinical, government, and non-governmental positions. Major area of study for medical anthropologists are: 1. Health ramifications of ecological adaptation and maladaptation. 2. Popular health culture and domestic healthcare practices. 3. Local interpretations of bodily processes. 4. Changing body projects and valued bodily attributes. 5. Perceptions of risk, vulnerability, and responsibility for illness and healthcare. 6. Risk and protective dimensions of human behavior, cultural norms, and social institutions. 7. Preventive health and harm reduction practices. 8. The experience of illness and the social relations of sickness. 9. The range of factors driving health, nutrition, and healthcare transitions. 10. Ethnomedicine, pluralistic healing modalities, and healing processes. 11. The social organization of clinical interactions. And 12. The cultural and historical conditions shaping medical practices and policies. 13. Medical practices in the context of modernity, colonial and post-colonial social formations. 14. The use and interpretation of pharmaceuticals and forms of biotechnology, the commercialization and commodification of health and medicine. 16. Disease distribution and health disparity. 17. Differential use and availability of government and private healthcare resources. 18. The political economy of healthcare provision. 19. The political ecology of infectious and vector-borne diseases, chronic diseases, and states of malnutrition and violence. And finally, 20. The possibilities for a critically engaged yet clinically relevant application of anthropology. So, students, let us summarize the module. What we learned is medical anthropology is a subfield of anthropology. The discipline of medical anthropology draws upon many different theoretical approaches. Medical anthropology examines how health and well-being are socially and culturally constituted in comparative and transnational contexts. Medical anthropology is the study of human health and disease, healthcare systems, and biocultural adaptation. Applied medical anthropology deals with intervention, prevention, and policy issues and analyzes the socio-economic forces and power differentials that influence access to care. Judge M. Foster and Barbara Anderson in 1978 traced the development of medical anthropology to four distinct sources. William Cordell in 1953 was the first to identify the field, followed by review articles by Stephen Polgar in 1962 and by Norman Scotch 1963. Anthropologists, using an ecological perspective to understand disease patterns, view human populations as biological as well as cultural entities. Medical ecology, unlike other orientations, assumes that biomedical disease categories are universal. The ethnomedical perspective focuses on health beliefs and practices, cultural values, and social roles. A key concept in ethnomedicine is explanatory model, introduced by Arthur Kleinman in 1980. The disease-illness distinction is important conceptually in the study of ethnomedicine. Cultural psychiatry is closely allied with ethnomedicine. Theories of the cultural patterning of health behavior can be applied in any arena. Critical clinical medical anthropology is an adjunct of political economy. Currently, research in medical anthropology is one of the main growth areas in the field of anthropology as a whole. Thank you.